So I heard your introduction of Susan today, and I mean, I can't believe you remember all that stuff, but nothing about your schooling or whatever. I've known you for, it's got to be 10, 12 years or so. This man changes lives. He's my rheumatologist, and I think most of you all know him here, and this is the reason that we're all here, is because he puts these things and he cares. So he's going to come up and talk to us about what's new with AS. Thank you.
Thanks, Gerald. I did most of my training in the States. When I came back to Toronto, there was a small organization called the Ontario Spondylitis Association. There's one in BC too. And when this Spondyloarthritis Research Consortium of Canada, SPARC, got born, there was a vision that really on the part of the rheumatologists and the patients that we really could work together more effectively. And it's just fantastic work that you and Wendy have done. It's very exciting to see this all coming together. It's really great. I'm going to, let's see if I've got, I think I'm preloaded here, I assume. Did you, Marie, I sent this, oh, here we go, okay, we got it here. So I'm the little preamble for Dr. Haroon, who's coming next to talk about the new treatments, but I'm going to talk, just give you a little snapshot of some of the issues that we're dealing with at the moment. Here we go. Back pain, no matter what profession you've got, having a functional back, whether you're reaping out in the fields, having a pain-free range of motion in the back is an important part of life. So that's the dominant issue, and this data actually comes from a survey that we did several years ago, actually with the Spondylitis Association of America, our sister partner organization in the US, about just the peak age of onset. This is interesting. It's a different curve than you'd see, say, in rheumatoid arthritis. Interestingly, that under 18 group, where patients are having their first symptoms, either in the back or peripheral joints, like hands and feet, it's about 18% of our clinic. So these are young kids in high school who are starting with back pain. Usually their parents assume it's a sports injury. They switch their skates or they switch their sport. And finally somebody circuitously gets them to see a rheumatologist. So they actually start off in the grade school, high school years, and then when they get to about 16 or 17, they get kicked out of hospital for sick children and they come over to see us. So it's quite a spread. And even some older patients too. But these are the most productive parts of a person's life, of course, and what we hear, picking up on some of the themes for tonight, is that in this age bracket from 18 to 30 are when people are deciding their careers, they're deciding graduate school, and they're deciding their spouses, and major life decisions are going on, and they're being impacted by this chronic disease. So that's heightens the sense of urgency and the timeliness of our intervention. This actually reproduces, the Canadian data is actually better than this, but this reminds us the dominant features that Gerald just highlighted very nicely with we're very excited about the Canadian survey. A couple of points of reference there. You can see, as Gerald mentioned, sometimes the first pickup is with the ophthalmologist with an episode of iritis or uveitis. And a lot of our ophthalmology community now are getting increasingly aware of AS and when to do a B27, when to refer. So that's very helpful. And if it's the first initiating event might be bowel inflammation like Crohn's disease or ulcerative colitis. And the same thing, we're trying to, with these experts in other disciplines, ophthalmology, dermatology, gastroenterology, trying to facilitate this recognition and these referrals. The sternal pain, I'll just make a comment there. I'm sure somebody in this room has experienced what we call anterior chest wall pain. This is we usually think of AS as affecting the low back, but when it affects the chest wall, it can be quite distressing, and it can be quite confusing if a patient arrives in the emergency room with chest wall pain, thinking they may be having a heart attack, and it's actually their spondylitis. So it's a major issue. We participated in something called the ASAS Health Index that's generated. It's a multinational set of indices that used a very large database, the International Spondylitis Association, to really look at some of the major impacts of daily life. So that you'll see terminology, the ASAS Health Index used in some of the surveys that are now circulating. It's very helpful. But you can see here just about every aspect in this particular, our initial questionnaire, every aspect of daily life, the things that kind of bring us joy and fun and distraction are impacted by ankylosing spondylitis. And it's significant, and it's, as we'll hear shortly from Susan, that the major impact on psychosocial adaptation is a huge issue. And we can see here, in fact, that you look at these major impacts. So whether as physicians, as rheumatologists, we tend, since our training is in looking at the biology and the physical aspect of the disease, we tend to see the disease through that lens. But we've learned from you that's too narrow a focus. We know now that just about the emotional and social impact of this disease is immense, as everyone in this room knows better than we do. When you look at these, how the health policy planners, this is international coding of disease, how you actually kind of comprehensively capture something like this. When it's something that starts with a local, maybe some T cells infiltrating the sacroiliac joint, but they affect your employability. Like you've got these different domains in this universe because it's affecting every aspect of life. So you can see that this is from the WHO, but they try to capture disease comprehensively because the biologist will look at one quadrant. It's the blind man and the elephant, right? The rheumatologist might be looking at joint inflammation. The psychologist will be looking at adaptation. The physiotherapist will be scaling their exercise. But at the center of all that complicated equation is the patient, and the patient struggling with the disease and trying to carry on as best they can. And all these contextual factors figure into it. So this is a great, we need machine modeling. I'm not ready for artificial intelligence. I'm just struggling with endogenous intelligence before I get artificial intelligence. But you can actually see that as we get more sophisticated in our data analysis, we can actually aggregate some of these very different domains, like the cytokine level and emotional well-being, and how exercises influences the immune system. Domains that we would usually think of as being disparate actually all come together. They come together in the patient. Now this is a slide, this actually from our survey originally with the Spondylitis Association American. We still see this slide as a bit of an indictment of ourselves as leaders in this field. So we asked the question, so how long it was that from the onset of your symptoms to the time you had a diagnosis made? So if you take the 50% cut there, like the lower two quadrants of this circle, you can see that at least 50% of patients had 6 years of symptoms before the diagnosis was made. Now, if you did that in rheumatoid arthritis, that would be totally unacceptable. You'd say, wait a sec, you had 6 years of painful swelling in your joints and nobody made a diagnosis? Or where they said, well, nobody got around to doing an x-ray. So it raises a lot of very important questions on the rheumatology side about the diagnostic or the classification criteria, but there's something this is a challenge, right? Because I'm sure many people in this room, and we hear it in the clinic all the time, before they finally got to a rheumatologist, they were seeing a physiotherapist and a psychiatrist and an acupuncturist and herbologist and a naturopath, and finally somebody said, maybe your inflammation in your eyes got something to do with your back pain. And they started to put the pieces together. So the reason I say this is a challenge for us is this battle really is not fought amongst the rheumatologists, it's in primary care physicians, it's sports clinics, it's physiotherapists, it's the healthcare practitioners that are actually seeing young people with back pain. That's where we really need to far more effectively communicate and at least raise the level of awareness. And this affects long-term outcome. As Dr. Hoon will say, there's evidence that the earlier diagnosis leads to early intervention, leads to better outcomes. And so we can see here that this is not just somebody struggling along with unexplained joint symptoms, it's actually going to affect long-term outcomes. So there's a sense of urgency, and I think very much we feel that on the rheumatology side, working with the CSA, this is really a joint effort because we're mutually invested in improving these data. Now, one of the challenges with, I use rheumatoid arthritis as a contrast, because a patient that appears at a busy general practitioner's office with swelling in the small joints of the fingers, if the GP misses the diagnosis that day, they'll probably be back 2 weeks later saying, I can't get my rings on, right? Maybe I should see a rheumatologist. That same patient with low back pain, the GP may say, well, we'll get you into some physiotherapy, take some NSAIDs, we'll see you back in 6 months. There's not much to really, in terms of the physical examination, there's not really much to help that GP to discriminate. And the problem here is that back pain is so prevalent in the population. And so the busy GP is seeing a lot of patients with coming, it's probably the 2/3 of patients are musculoskeletal, seeing a GP, and back pain is a dominant reason for people to see their doctors. So there's a lot of background there. So what we've been trying to work with, and this is with ASAS and the CSA and SPARC, is how do we actually raise the index of suspicion appropriately? So these are some of the kind of grids on our side of the street that we work with. So a younger patient with back pain, not to say that, as you saw, AS can be actually diagnosed in the 50s, but we're looking at younger patients with at least 3 months of back pain, sustained back pain. So if we begin to introduce that level of awareness of suspicion, you see, if a GP or a physiotherapist or a sports physician is seeing a young patient with chronic back pain, this should register. And then those who have been through our clinic many times, we use these indicators that might shift the probability away from what we call mechanical back pain to more inflammatory back pain, as from, say, disc-related problems to ankylosing spondylitis. And some of these features you would know well. Morning stiffness, for example. Lauren and I saw a patient recently in the screening clinic, and it was so striking. It was a young guy, 26 years old, with a year of back pain, and it really took him an hour to get going in the morning. Like, it was really striking, and bingo, he had diagnostic changes on a sacroiliac joint after even just a year of symptoms. So we use these variables. None is completely diagnostic. They just shift the probability. So these are the questions that ideally we'd like our GPs to be conversant in these. Now, besides the characteristic of the back pain, and when we're talking to our family practice residents or our medical students, we would alert them to, if you see anything else going on besides the back pain, that changes the equation. So is there arthritis in the joints, like knees, feet? Is there Achilles tendonitis, or what we call enthesitis, or heel pain? Is there any evidence of swollen digits, dactylitis? So it mandates a good physical examination. We teach our medical residents and our medical students to always look not just at the back pain, but look at the whole patient. Imaging is important. I'll talk about that in a second. And as you're aware that we use a lot of imaging in our clinic modality. Sedimentation rate and CRP, you're probably familiar with those terms. They're totally nonspecific. If you slipped on the ice coming into the clinic, or you had the flu last week, they're going to be up for other reasons. So they're neither specific nor sensitive. And yet, we don't have any cool autoantibodies like our lupus friends have got, but that's the best. The response to NSAIDs is interesting because it's not unusual that a GP would at least start somebody on Motrin or Advil or naproxen to get started on the back pain. And sometimes the degree of improvement in back pain can be a surrogate marker for how much inflammation is going on. B27 is present in about 80 to 85% of our patients, and a family history is very informative too. Not just of spondylitis, but do you have any family members with Crohn's disease or iritis or psoriasis? They all cluster together genetically and clinically. Predisposing factors, well, we have an interest in we have several patients in our clinic whose spondylitis clearly started with an infection. They went abroad, they got a gastrointestinal infection, and they had what's called reactive arthritis, and then over time that seems to evolve into AS. So in terms of the research agendas, there's a great deal of interest on both clinical and basic science about what the nature of that trigger is. What kind of infection can actually start this process to begin with? We certainly recognize that HLA-B27, if somebody develops an arthritis after, say, a gastrointestinal infection, the likelihood of it going on to a chronic arthritis is tremendously increased if they've got this particular HLA-B27. And then psoriasis, Crohn's disease, and uveitis, as Gerald just mentioned, these are kind of their classical features. And so we would certainly try to alert general practitioners and physiotherapists that if they're taking a history, somebody, a young person with back pain, if they've got any of these features, all of a sudden the light should go on, right, for a referral to rheumatology. I mentioned the fact that our physical examination lacks some of the sensitivity that in, say, when you've got small joint inflammation, like in rheumatoid arthritis. We do, everybody's done these in our clinic. We're really big on measuring back mobility. But if you went out to the airport and lifted up your suitcases tonight and got a back strain, and we brought you into the clinic and had you do this back mobility, it would be very restricted. So you could have restriction in back pain and back mobility for other reasons than just spondylitis. But in an established AS population, we do use it as a marker, these measurements of progression over time. And then, of course, lateral spinal flexion as well. The presence of iritis. And as I mentioned, we have close connections with the ophthalmology community in Toronto because they both, we referring to them and they referring to us when there's complications. This is a significant issue. I'm sure, well, statistically, 33% of the people in this room would have had uveitis. Happily, if it's treated aggressively with topical steroids, Predford, it can get under control nicely, but it can lead to secondary glaucoma and cataract formation. Enthesitis, I mentioned, significant issue in some of our patients. So X-rays forming a really important part of our diagnostic assessment, probably much more so than, say, rheumatoid arthritis and certainly lupus, because the X-ray changes of spondylitis are really quite distinctive when they're there. So we see for somebody in the spine, and the real hallmark are these bone spurs, right? So the bone spur, which we call syndesmophytes. So under normal circumstances, what allows our spines to move normally in a pain-free way is these intervertebral discs have flexibility. But if you throw a little bone bridge across the disc there, where that arrow is, instead of a pain-free range of motion, it's getting restricted, right? So that's a very distinctive picture for ankylosing spondylitis. That's what we're out to. So one of the questions is, can't we do better in making a diagnosis earlier by earlier referral? So this anticipates, Laura's going to come up shortly talking about the importance of exercise. I'm probably stealing your thunder, but no, she's okay. Thumbs up. So this is recognizing there's an issue, there's a challenge in early recognition of AS, particularly now that we have good effective treatments, how do we actually do better? So Laura's actually taken a really important lead on this, and we realized that with the prevalence of back pain and the number of rheumatologists in Canada, which is about 360, we really don't have the bandwidth to cope with this. We have to have a better strategy for early identification of patients. So Laura's taken the lead with Dr. Raj Ramprasad here at Toronto Western on a screening program that evaluates back pain at the population level. So we have 3 nodes in the study: Thunder Bay, Hamilton, and Toronto. So the intake is not the physician. The intake either comes through, it's not a rheumatologist. The intake comes from GPs or from chiropractors into physiotherapists and trained chiropractors that are familiar with AS. And the idea really is to create a far more effective triage system, what we call the Spondylitis Screening Clinic. It's a work in progress. It's great. We're trying to clone this across Canada. Some of these people have trained with us, and our best model, working with the CSA, would be to have a rheumatology champion and a physiotherapy champion in each site, so we can actually do better on this. And then so that's really models of care. It's a healthcare quality issue. The other issue is, how about in the clinic? Can we do better imaging? Well, one of the challenges here has changed everything, is the presence of MRI. So this is a typical MRI. That little white spot there represents inflammation, or what we call bone marrow edema. That's called a stir sequence, and many people in this room have had the joy of sitting in an MRI for an hour. It's kind of creepy, I'm sure. I've done it. But that is really quite distinctive. So the MRI has turned out to be very important. When the X-rays are non-diagnostic, the MRI can really help us significantly. And so it's led to this kind of model. So we've got ankylosing spondylitis. That's the New York criteria. They were established back in 1994. Still pretty much the gold standard for most clinical trials in genetics. By that time, we've got distinctive changes in the sacroiliac joints. So these blurred changes in the sacroiliac joint are very distinctive. But that timeline is lengthy, you know. So, for example, we don't wait for damage to occur to a joint to make a diagnosis of rheumatoid arthritis. So why would we wait until there's damage to the spine? So that's where the MRI has really been helpful. So we have this rather bulky term. From ankylosing spondylitis, we get that. But now we've got this crazy term, non-radiographic axial spondyloarthritis. Can repeat after me. I mean, that's a very, not only, it's a bulky term, it's not a really great term. Even from the government and the insurance company industry point of view, what is non-radiographic axial spondyloarthritis? Now, some of these people, our people in the room here, know what it is. They've got all the symptoms. They're B27 positive, but their x-rays are non-diagnostic, but the MRI points out they've got inflammation. So we have no modalities now, at least to be able to detect the disease earlier. And we think that obviously this timeline where you go from an MRI that's positive in the back to an x-rays that's showing changes to actually the bony bridges, the syndesmophytes. We really want to stop this timeline before we move too far down the pathway. So it's kind of if you look at the back pain population in the province of Ontario, incidentally in Dr. Roon's study in the cardiac complications, the survey in ISIS database, about 24,000 AS patients in the database of ISIS. If you look at how it evolves, so there's a sort of a heterogeneity or variability in the course of this disease. So you could start up here with, we're not quite sure, if somebody just presents to a GP with inflammatory back pain, some will probably go into spontaneous remission or respond to NSAIDs. They've never seen a rheumatologist. They're doing fine with their physio and their NSAIDs. Some will then follow into a more quiescent category. This has been an issue with the natural history of this non-radiographic form, like how many actually, do they need to be on biologics? Do they need to be on NSAIDs? Some evolve over time into late complications. Some go into a pathway that is really non-progressing. So a lot of what we do in our clinic, our team does, is actually, at the moment, that's very descriptive longitudinal data. But if we have a young person in their 20s up there upstream, are there genetic markers or serum biomarkers or clinical characteristics that actually can allow us to prognosticate more accurately? So that's a lot of, I know it's tiresome to do the questionnaires in our clinic, but this is sort of what the strategy has been. So we're trying to work with this, again, working with the people that see back pain on the front lines. What constitutes the best screening mechanism? The most cost-effective with the least false positives and the least false negatives. And this is going on. And so algorithms like this come on. So if we're talking to a group of family practice residents, to alert them, if you see a young patient with back pain, how do you actually start? Because often the first x-ray is not even the appropriate x-ray. They may do a lateral lumbar spine when in fact we need to look at the sacroiliac joints. So this is a solvable problem. We believe it. We're working on it. It's an education challenge for us. I think we're up to it. Spark runs annual resident research and education days. So we get all the rheumatology residents from all the training programs in Canada come to Toronto for an intensive day and a half of x-rays, labs, physical examination. We really try to concentrate that. Genetic factors are important. These are two twins from the Philippines. Their x-rays are exactly the same. They're both HLA B27 positive identical twins. Their x-rays are indistinguishable. They actually have had both hips replaced. HLA B27 is a very important marker. And wherever you go in the globe, if there's a lower frequency of this gene, there's a much lower frequency of ankylosing spondylitis. It kind of tracks around all ethnic and racial groups. This gene seems to still have a dominant susceptibility effect on ankylosing spondylitis. This is what's called the Manhattan plot, where basically the geneticists screen our whole genome to see which genes are actually associated with spondylitis. And the big tall tower there is B27. HLA B27 is the dominant genetic element. It's called a Manhattan plot because somebody thought it looked like the Manhattan skyline. We actually think in rheumatology, we think of it this way, right? It's actually the Toronto's plot, all right? So every time a spondylitis expert looks at the Toronto skyline, they see this big B27 effect. So, and just to wrap up, it's not just genes. So having B27, so and 85% of patients with AS have the gene, but if you've got the gene, only 2% of patients will have ankylosing spondylitis. So it has both sensitive, but actually fairly poor sensitivity. So the issue is, what else is going on? If there's so many people out there with this gene but don't have AS, so that gets us into the issue we just talked about infection, triggers. Somehow the genes set the stage. There's something provocative, almost certainly other genes acting in concert, but environmental factors. And we believe that, for example, infectious triggers, diet, the microbial population in your gut, the so-called the gut microbiome, is a big thing. So research in AS, just to finish up, covers many things. It goes all the way from sequencing DNA molecules to looking to see how B27 affects cell biology. But ultimately, we're really looking at how it affects the disease, and not only the patient population, but the population at large. So it runs really all the way from molecular biology to population health and clinical epidemiology, and a lot in between. So it's a multidisciplinary disease, which calls for a multidisciplinary approach, and this is some of our team. You can see that it does include epidemiology and physiotherapy, surgery for sure, pharmacology, and happily we're part of an international network. So we've actually these are just some of our international fellows that have trained with us and gone back with the message, gone back with the gospel to take the message of early detection of ankylosing spondylitis to their home countries.